of topical atropine in the field of myopia control treatment with these learning objectives, including the currently available pharmaceutical options, the evidence for the application of different pharmaceutical interventions, the clinical data about the range of slowing myopia progression in using the currently available pharmaceutical strategies. Currently, myopia control is imperative. And since the beginning of 21st century, there has been a lot of critical evidence to support that myopia needs to be efficiently controlled to reduce the future risk of visual impairment and blindness, thus the future social burden. In fact, recent evidence indicate that each diopter successfully controlled by myopia control treatment can significantly reduce by 40% of risk of visual impairment related to myopic macular disease in later phase of their life. Until now, there was no treatment to completely prevent the development of myopia or to stop the progression of myopia. So with that respect, the critical aim of myopia control treatment is to slow the progression of spherical equivalent and the axial elongation. With respect to the title of this presentation, I mainly focus on the pharmaceutical interventions. There are multiple compounds that has been investigated as potential myopia control strategies, including the intraocular pressure lowering agents such as timolol, with the hypothesis of reducing the stretching force on the ocular wall, the cycloplegic agents such as the propicamide or cyclopentolate, the selective antimuscarinic receptor agents such as the pirenzepine ointment. However, due to the inconsistent proven effect or unknown reason, they are no longer pursued in a further investigation. We can move a little bit to the details. For example, the topical timolol, a beta blocker that has been used to lower the intraocular pressure, was initially suggested that can slow the ocular elongation by reducing the stretching force on the ocular wall. However, the myopia control effect has not been proven in humans. Another option is the topical ointment pirenzepine, a selective antimuscarinic receptors, which only selectively antagonize the effect only on M1 and M4 subtypes of the muscarinic receptors, was another potential candidate. Despite some promising efficacy from initial reports, it has been no longer pursued with unknown reasons. Therefore, today, atropine, a non-selective muscarinic receptor antagonist, and xanthine, non-selective adenosine receptor antagonist, remain the currently available pharmaceutical intervention for myopia control treatment. Xanthine, especially 7-methylxanthines, are known as 7-MX, an adenosine antagonist or a metabolite of caffeine and cacao. It's well known that can affect the increase of the heart rate, the contraction of cardiac smooth muscle, or the alteration of neurosignaling in the central nervous system. But its use is still only in Denmark as tablet, and the myopia control efficacy in the previous data of using 7-methylxanthines appear to be limited compared to other currently available myopia control interventions. 7-MX as well as caffeine show promising data over the trials on primate. However, more work needs to be conducted to define if xanthine or caffeine topically may contribute in controlling myopia progression. Recently, in April 2022, our poster from the study in Vietnam suggests that topical caffeine at the concentration of 2% appear to have no efficacy on myopia control, but topical caffeine can significantly reduce the side effect of atropine while using as a combination eye drops. Therefore, it may open an opportunity to use the higher concentration of atropine with tolerable side effect by combining with caffeine eye drops. More trials need to be conducted in the future to clearly prove the role of sampling or caffeine in myopia control treatment. In overall, topical atropine remains the only pharmaceutical intervention that has been proven effective in controlling myopia progression with various concentration from 0.01% up to 1%. Despite being off-label status, topical atropine is still widely used in many countries around the world due to the clinical motivation, especially in the Asian countries. Atropine is a tropane alkaloid, which is mainly extracted from the plant named Atropa belladonna, a poisonous plant. Since the 19th century, atropine was firstly used to dilate the pupil for beauty purposes. And since 1960, atropine has been approved for topical use in the US, with the main indication including the mydriasis and cycloplegia, both for the diagnostic and treatment purposes, in addition to the treatment for amblyopia. The first reports for the use of atropine in myopia control treatment were published since the year of 1970s and 1980s in US, and broadly adopted in many parts of the world since the end of the 20th century and the beginning of 21st century. Following the critical warnings and precaution, topical atropine should not be prescribed in clinical practice if there is the history of allergy to atropine or any related chemicals or ingredients of the eye drops. If there is the history of heart disease or lung disease, or any pre-existing eye disease, for example, glaucoma. A network meta-analysis published by Huang et al. In 2016, the most recent network meta-analysis comparing data between different myopia control interventions, support the greater efficacy of atropine eye drops for myopia control than that observed with other strategies. Despite being off-label treatment in many countries, topical low-dose atropine is the most prescribed pharmaceutical intervention, and the dose of choice mainly depends on which concentration available in each part of the world. And here are the evidence-based clinical data. I plot a graph showing data of multiple studies worldwide investigating myopia control with atropine eye drops. On this graph, the red bars are showing the efficacy on the progression of spherical equivalent, while the green bars are on the efficacy of on the axial elongation. There are three things that I would address to. First, the effectiveness of atropine in controlling myopia progression is consistently shown with respect to both spherical equivalent as well as the axial length. Second, the increased number of studies in using atropine eye drops in the recent years due to the clinical motivation, especially in the Asia-Pacific region. Third, nearly 50% of all the studies and up to 90% of the trials over the last 10 years report data of using atropine at the concentration less than 0.1%. This clearly illustrates the emerging application of low concentration atropine for myopia control treatment in many parts of the world. We are moving up with the big clinical trials. First is the ATOM-2. In 2016, Kia et al. Report the 5-year data of about 400 Singaporean children with myopia treated by topical atropine at 0.5%, 0.1%, and 0.01% over 3 phases, including 2 years of nightly eye drops, 1 washout year with no treatment, in addition to 2 more years being with 0.01% atropine if the progression was worse than minus 0.5 diopters over the washout period. Observing the graph for the first 24 months, topical atropine significantly slowed the progression of annual spherical equivalent between the 60 to 75% for the dose of 0.01 to 0.5% atropine respectively. However, during the washout period with no treatment for all groups, significantly steeper rebound effect, which means greater myopia progression were observed in higher concentration. Over 5 years, patients who had 0.01% atropine for the whole time show significantly less overall progression with minimal side effect, while patients who had higher concentration, here is the 0.1 and 0.5% atropine, show greater overall progression with 1.8 and 2 diopter respectively, compared to 1.4 diopter found in the group of using 0.01% atropine. ATOM2 was the first randomized clinical trial which opened the application of low concentration atropine for myopia control treatment. However, due to the use of historical control group and the lack of support for the efficacy of 0.01% atropine with respect to the axial elongation, further trials can provide stronger support for the use of low concentration atropine. We are moving on with LAMP study, another big randomized control trial. LAMP study, low concentration atropine for myopia progression, was the largest randomized placebo-controlled trial to date for the use of low concentration atropine with 0.01%, 0.025, and 0.05% atropine versus placebo control group. Until now, LAMP study has been reported to the phase 3, the year 3, and is currently monitored for the phase 4. The randomized placebo control group was followed for the first year prior to being switched to the use of 0.05% atropine for all participants in the control group in the second year. You may see that with the green line. In the third year, the switchover group kept going with the use of 0.05% atropine, while 3 atropine groups were randomly assigned to be followed up with atropine or with no treatment over 1 more year. You may observe the dot lines for the participant on the washout and the solid line for the participants on atropine. In overall, the myopia progression with 0.05% atropine was significantly lesser than that observed with other concentration and the control group. Although 0.05% was reported with greater rebound effect, while the rebound effect with 0.025 and 0.01% atropine was found statistically insignificant. The overall progression of washout participants in the groups being previously used with 0.05% atropine was lesser than participants being continued with 0.025 and 0.05% in the third year. Moreover, the mean difference of axial elongation between the washout group of 0.05 versus washout group of 0.025 versus 0.01% was only 0.04 millimeter per year, which can be considered clinically irrelevant. Altogether, there are few recommendations that we could take home. 0.05% atropine is a good concentration to start the treatment with minimal side effect, and it's not advised to start with lower concentration, including 0.025 or 0.01% atropine, then increase to higher concentration in later phase. In the third year, continuing 0.05% atropine appeared to be a better approach than stopping the use of atropine. And the third one is the tapering to 0.025 or 0.01% atropine rather than no treatment was suggested to minimize the rebound effect if 0.05% atropine was previously used. To delve into the myopia control efficacy of low concentration atropine and to suggest a concentration of choice for the application in the clinical practice, there was a recent network meta-analysis that include data only from the RCTs and analyzed 30 pairwise comparison from 16 RCTs and over 3,000 participants from 8 different concentrations between 0.01% and 1% atropine. The forest plot here on the slide exhibit the effect of different concentration on the change in annual spherical equivalent in the green color and in annual axial length in brown color. All concentration appear to efficiently control the progression of myopia with respect to spherical equivalent and axial length. Amongst all concentration, 1%, 0.5%, and 0.05% atropine appear to be the most beneficial for myopia control treatment, with the mean difference compared to control of change in refraction being 0.81, 0.70, and 0.62 diopter per year respectively, whereas the change in axial elongation being minus 0.35, minus 23, and minus 25 millimeter per year respectively. While the myopia control efficacy of 0.05% atropine appear to be comparable to that observed with higher concentration at 0.5% and 1% atropine, the dose-related relationship with respect to side effect therefore support the application and the uptake of the concentration of 0.05% atropine in the clinical practice. Another recent meta-analysis delved into the side effect analysis by meta-analyzing the 6 RCTs and 7 observational studies with over 3,000 participants. This meta-analysis was conducted by us and recently published in APJO in 2020. Regarding the amplitude of accommodation, all concentration excepting for 0.01% atropine result in a significant reduction of accommodative amplitude with the mean change at minus 4.67 diopters. Observing the forest plot, we can observe the green oval for the groups using less than 0.1% atropine and the red oval for the groups using 0.1% atropine and above. The authors suggest a significant greater reduction in the groups at 0.1% and above than that observed in the groups using the concentration less than 0.1%. In fact, there was variation in the technique used to measure the accommodative amplitude between studies. However, rather than absolute values, the authors report change in accommodative amplitude and compare them to control in those studies. Therefore, the effect of such variation were likely minimized. We move up to the pupil size, the effect on pupil size. Similar pattern was also found with respect to the increase of pupillary diameters. All concentration of atropine dilate the pupil with the mean change of 1.33 millimeters and 95% confidence of interval range between 0.57 to 2.09 millimeters. Observing this graph, the green oval for the concentration less than 0.1% and the red oval for the concentration at 0.1% and above show a clear difference between two subgroups. This relationship was examined further, and the authors found a nonlinear dose-response relationship with a steep increase with the effect versus dose at the concentration less than 0.1% atropine, and a more plateau change for the curve for the concentration at 0.1% and above. The trend was similar for both the side effect, the pupillary dilation, and the reduction of accommodative amplitude. Moreover, when the authors weighed the mean difference between two subgroups, less than 0.1% atropine and at 0.1% atropine and above, they appear to be significantly different between two subgroups with respect to both the change in pupil size and in accommodative amplitude. Therefore, it suggests that 0.01% could be the new cutoff point to define at the high concentration at 0.1% and above, and low concentration of atropine less than 0.1%. Our findings were aligned with published reports where many reports of photophobia or near-work problems were infrequent in those using the concentration less than 0.1%. Interestingly, similar pattern was also observed in considering the rebound effect over 1 year cessation of atropine eye drops in ATON 1 and ATON 2 of the Singaporean teams. Moreover, although the relationship indicates a steep increase of change for concentration less than 0.1% atropine, previous report also found no significant difference in the rate of side effect with the use of 0.05 or 0.025% atropine. It could be explained by the large reserve of compensation in the young kids. Recent data from reports of LAM study also illustrate and support that idea. Although LAM study, a well-conducted randomized controlled trial for the use of 0.01 versus 0.025 versus 0.05% atropine, report a dose-dependent efficacy and side effect of myopia control treatment. This table shows that there was neither higher need of photochromatic spectacles nor higher need of progressive glass between groups using 0.05 or 0.025 versus 0.01 or placebo control groups. One interesting finding in this study is that in the placebo groups, nearly 40% of the participants did ask for photochromatic spectacles, and 30% of participants report photophobia at 2 weeks. The authors therefore suggest that the subjective symptoms of photophobia came from the wariness of the caregivers, not from the treatment. Therefore, a comprehensive consultation or a comprehensive explanation about the benefits and the risks may help the uptake of the use of 0.025 or 0.05% atropine if it needs to be prescribed. Moreover, despite statistically significant reduction of accommodative amplitude, especially in the groups of 0.05 and 0.025 atropine, LAM study report negligible reduction of near visual acuity in all groups, and the near visual acuity remain functionally good enough for children for their schoolwork and near activities. That point also aligned with only a very small number of children in all groups did ask for progressive spectacles. Other than pupillary dilation and reduction of accommodative amplitude and rebound effect, there was no report to date about any serious adverse effects over the use of atropine eye drops with the study with more than 10 years follow-up. However, there was a small percentage of non-responder that has been reported over study, especially in ATOM3, with the non-responder has been reported up to nearly 10% with 0.01% atropine. Therefore, recent evidence also support the fact of switching to other optical strategies or combining with optical strategies, which recently showed promising myopia control efficacy. In fact, data of using atropine in the combination with orthogate is now available and promising. On this graph, we only analyze the efficacy on the axial length. The blue is for orthogate alone. Yellow is for the combination of orthogate plus low concentration atropine, and the green of 0.01% atropine alone, and pink with for the other low concentration atropine. Compared to orthogate and or 0.01% atropine in monotherapy, the study of Kinoshita and co-workers in Japan was a well-conducted RCTs and support the superior myopia control effect of the combination therapy over monotherapy, especially for the change in the axial length. Therefore, it suggests another good option for the clinician in daily practice. However, the number of evidence is still limited, and we may need the result of further trials in the near future to clearly prove the efficacy of combination therapy. In summary, there's evidence to support the pharmacologic intervention in slowing the progression of myopia, especially with the emerging uptake of the low concentration atropine, less than 0.1%, as the key pharmaceutical intervention in many parts of the world. Low-dose atropine can be effective with minimal or nearly no side effect. 0.01% atropine as preferred dose is now being challenged by the new data supporting the uptake of 0.025 or 0.05% atropine in the clinical practice. Moreover, despite the dose-response relationship, the side effect over the use of atropine at the concentration less than 0.1% is now reported tolerable. In fact, the side effect, including pupillary dilation and reduction of accommodated amplitude with low concentration atropine at the concentration less than 0.1%, the average change in the pupil size was less than 1 millimeters, and the change in accommodative amplitude was less than 2 diopters, which were unlikely to result in any significant symptoms, as children tend to have the large result of compensation. However, 0.05% was supported by current evidence to be the low dose of choice in the clinical practice and to start off the myopia control treatment with the pharmaceutical interventions. Regarding the rebound effect, it can be minimized by dose tapering strategies and the fact that clinicians can safely continue the use of atropine to up to 3 years with data of the phase 3 of LAMP study. Or restart the use of atropine eye drops during the cessation period if the progression is worse than minus 0.5 diopter per year. Therefore, all patients needs to be carefully monitored with critical protocol, and from the recent consensus of the AOC for the atropine use, it could be monitored after the baseline 1 week, 1 month, 3 months, and 6 months, and 6 monthly follow-ups after that. The protocols should include especially the change in annual spherical equivalent, annual axial elongation, and the side effect. Switching to or combining with other optical strategies, including the orthokeratology or the novel optical intervention, has been supported by recent evidence. More work needs to be warranted to clearly prove, to clearly explain about what criteria of selection for the patient and what those of the treatment if we need to choose in each particular case. And here are the main papers that you may find interesting information about the topical atropine use and its application in the clinical practice. And finally, I hope that you've enjoyed the meeting until now, and you may find some practical